you to the organizing team for giving me this opportunity on this evening. And this talk is all about the other aspect of management of fracture neck of femurs. The whole idea of fixing these fractures is to make the patient mobile and to prevent any medical complications. So we need to have some understanding as to what medical complications can happen post-operatively for the patients and how to prevent them. So an elderly person will have an average of 2 to 5 comorbidities, and some of them are listed there. And the concept of orthogeriatrics is that when compared to the young patients, the comorbidities are much higher compared to the surgery and anesthesia a bit of the whole patient. And there are many areas of management that we need to concentrate on when we look into these patients. So outline of the talk is that we'll briefly touch upon the prevention of thromboembolic events and the post-operative care, prevention of delirium and other complications, as well as how to prevent future fractures in the same patients and the discharge planning. One word of caution, especially for the juniors, that the preoperative traction for fracture proximal femur patients is not at all recommended by any scientific evidence, and it is detrimental in most patients, and we have seen enough amputations being performed for vascular complications following traction application. So patients do not need any preoperative traction. When with regards to the general or regional anesthesia, lots of trials are there, but the overwhelming support is to the regional anesthesia in terms of reduction of mortality as well as thromboembolic events across the patient age groups. DVT and PE still one of the commonest complications following fracture neck of femurs. The proximal DVT incidence is up to 27% if you look into venographic studies or the ultrasound guided studies, and PE causes about 15% of all deaths after hip fracture surgery. So traditionally it was thought that in India the DVT rate is low compared to the Western standards, but as you look more and more into these things, when you look more scientifically, the PE incidence is significantly high. So the advanced stage, delay in surgery and general anesthesia are associated with increased risk of PE. The mechanical devices like stockings or any pulsatile compression stockings, they are definitely useful than doing nothing. Aspirin is used traditionally but not as effective as other options, whereas newer anticoagulants like the dabigatran or the apixaban as well as rivaroxaban, they are slightly better than the traditional Clexane with regards to the increased risk of bleeding. Again, the low molecular weight heparin, the subcutaneous dose, still remains the gold standard for prevention of PE in these patients. So in summary, the routine use of one of the anticoagulants, either low molecular weight heparin or oral anticoagulant, is recommended based on current scientific evidence. Some also use warfarin or coumarin derivatives, but maintaining the INR within the range is not that easy. Aspirin alone is not sufficient as PE prophylaxis. This has been discussed on numerous occasions in the past, although the literature is not convincing, but aspirin alone is not recommended as of now. If surgery is delayed beyond 24 hours, better to start Clexane preoperatively as well. And if surgery is not delayed, certainly start low molecular weight heparins within 12 to 24 hours after surgery, and continue anticoagulation for at least 4 weeks following any hip surgery, because studies have shown that if the anticoagulation is stopped beyond first week, the recurrence of PE is almost as much as if the patient was not put on any chemoprophylaxis at all. The patient perception of pain is something that is very important to identify. As a surgeon, we would not know how much pain a patient is in. So the only way to assess is to actually ask the patient and use some tools like visual analog score or scoring from 1 to 10 or something like that. Occasionally, patients will be very much confused and they may not be able to tell you as to how much pain they are in. In them, non-verbal clues like the level of agitation or tachycardia disproportionate to the blood loss or any facial expressions will give us the clue. And with regards to the epidural or patient-controlled analgesia or intermittent administration of morphine or morphine derivatives in India we commonly use, there is no clear-cut difference of one over the other. Epidural seems to be slightly beneficial in terms of continuation of, a sustained pain relief, but the risk of respiratory depression, and in patients with delirious conditions, the risk of the catheter being pulled off is slightly higher. So all in all, the most practical solution is to give intermittent administration of painkillers judiciously, but at the same time very cautiously, because a lot of these medication can give rise to secondary complications. And poor pain control in itself can lead to delirium, and that is something that we need to be aware of. Cardiac monitoring is also important. About half of all cardiac events in post-operative period are silent, so we need to take the help of a physician or the cardiologist to monitor them. Troponin levels, when in doubt, serial ECGs will give you a better perspective of the amount of morbidity the patient might be undergoing. The routine ECG may or may not be sufficient to identify the pathology, but certainly the troponin level is more important. The highest risk for any cardiovascular event following surgery is within the second to third day post-operatively, which is when we need to be very careful. With regards to the drain, whether to insert or not to insert, the trend is towards not putting any drains in most surgical situations these days, because of the risk of possibility of contamination through the drain site. Foley's catheter, most of the elderly patients, because of pain or because of pre-existing prostatic problems, will have some problem with passing urine, and in them, when you have to insert a catheter, the best is to put intermittent in and out catheterization, which is superior to an indwelling Foley's. If you were to put a Foley's, then certainly we have to remove it within 24 to 48 hours, because the overall incidence of UTI is about 25% in these patients. And the commonest medical complication following hip fracture surgery is delirium, confusion state. Most elderly patients are not used to be admitted into the hospitals, and because of the pre-existing medical conditions, they get delirious, and it is a marker of bad outcome following surgery. It increases the mortality and also increases the length of stay, as well as worsens the functional status recovery post-surgery. Advanced age, underlying cognitive impairment, as well as alcohol abuse or malnutrition are the risk factors for delirium, which we need to find out. And most importantly, using any restraints and using medication which make patients more drowsy, poor pain control, indwelling catheters, and other restraints actually increase the risk of delirium, so we need to be aware of that. And some medications like anticholinergics and antipsychotics, things like fluoroquinolones, like ciprofloxacin, can also increase the chance of delirium. The other important aspect is the delirium in itself may be the surrogate marker of an underlying systemic complication that the patient is going through, like the metabolic disturbances, electrolytic disturbances, underlying pneumonia, UTI, or even postoperative infection, postoperative site infection can present like delirium in an acute confusional state, as well as urinary retention, sleep disturbance. So all these things need to be considered when we face a patient with in a delirious condition, and to prevent identifying the high-risk patients, and as well as maintaining the family contact with the patients rather than keeping them for a prolonged period in the ICUs or in isolation areas, bringing them back to the wards, keeping them in touch with the family and their familiar surroundings, as well as reducing the amount of medication that they take so that there are few interactions is important. And malnutrition is another important thing that we need to identify and treat accordingly. Pressure sore prevention is very, very important. It can go up to 40% in patients if not taken care in the early stages. Frequent turning, weight bearing as tolerated, and removal of catheters and indwelling lines to make them unable to mobilize early is important. So various ways of assessing who is at risk of developing these, and looking into the risk factors as to who is more likely to develop pressure sores and trying to prevent it, and also looking at the skin called as surface, the skin inspection, keeping them moving, preventing incontinence, as well as taking care of nutrition is very important. And pneumonia is another important thing. The risk is less with regional anesthesia, so whenever possible, try to go for a spinal or the epidural anesthesia rather than a general. And blood transfusions need to be liberal transfusion. Just to keep it above 10 is not at all recommended. The important thing is, as long as it is above 7, if the patient does not have underlying cardiac condition or if he is not hemodynamically disturbed, no need to give any transfusions. As well as prevention of further fractures is very, very important. Osteoporosis, preventing further falls, preventing further fractures even if the patient falls is very important. 70% of patients over 80 have osteoporosis, and older patients are more likely to have fracture than the younger patient, although the BMD is same. This is because of the brittle bones and lot of other comorbidities that they have. When you look into the discharge summaries, only 1/5 of all fracture neck of femur patients have been prescribed any form of treatment for osteoporosis. So this is something that we can improve upon. The important thing is to give calcium. Lots of elderly patients do not take adequate amounts of calcium. We need to give at least 1500 milligrams a day. As well as vitamin D. As we all know, vitamin D is overtly deficient in lots of patients these days, and it is very unlikely that we can overdose these patients. So if you cannot get a blood test for vitamin D, just treat them adequately. As we all know, with 60,000 international units of vitamin D every week for 8 weeks following fracture neck of femurs, to maintain a vitamin D level between 30 and 60. In terms of active treatment for osteoporosis, calcitonin, yes, can reduce the pain from vertebral fractures, but not very effective on its own. Estrogen replacement therapy has slightly fallen out of favor because of concerns of increased cardiovascular risks in women. Bisphosphonates still remains one of the gold standards, which is easy to administer, which decreases the bone resorption. Alendronate weekly once, risedronate weekly once, or zoledronic acid, which is yearly once, is commonly used. One more minute, please. And with regards to zoledronic acid, which seems to be the most promising agent these days because of less risk of esophageal irritation, as well as more compliance because it's yearly once infusion, which can be given. And the consensus is that within just after 2 weeks after the fracture, once the wound healing is done, we can safely give zoledronic acid. The previous concerns about the fracture healing are not found to be statistically significant these days, and there is significant reduction of new fractures and mortality with usage of zoledronic acid. And teriparatide is also very useful tool, and that is actually much more safer than bisphosphonates, but it is more expensive and cumbersome to use for the patient. And prevention of falls is another thing that is important. Hip protectors, like any soft cushions like things around the hip that prevent further fractures, are used but not very effective. Discharge planning also very important. What type of walking aids that the patients need, and how's the home environment, whether they need some inpatient rehabilitation or some other step-down facility that we need to think about. So to just quickly summarize, regional anesthesia whenever possible, weight bearing as tolerated as early as possible, Foley's catheters to be removed within 24 hours, aggressive prevention of pressure sores, pneumonia, PE prophylaxis for all the patients, preventing delirium, do not routinely transfuse unless the patient is hemodynamically compromised, improve the nutritional status, always look into the osteoporosis. Everyone should receive calcium and vitamin D, and most patients would actually benefit from some form of anti-resorptive therapy or anabolic therapy. Thank you very much.
Extensive lecture. A small memento from the Orthopedic Society here.